بسم الله الرحمن الرحيم. أعزائي طلبة السادس، أنا دكتور عجيل محمود العجيل. تحت الظروف الراهنة اللي إن شاء الله يسلم البلد منها، قررت أنه أخلي الداتا انتربريتيشن اللي المفروض أعطيكم إياها على اليوتيوب. So this is the data interpretation hematology part 1. It will take about 40 minutes. Please follow with me the slides. This is case number 1, a 25-year-old female Cypriot complaining of tiredness. Her full blood count shows a hemoglobin of 10.5, MCV 65, RBC 5.5, MCSC 32, and RDW 12. As you see, this is a microcytic anemia, and I'm sure you all know the differential diagnosis of microcytic anemia. Obviously, the commonest is iron deficiency anemia. The second is thalassemia, and with this hemoglobin of 10.5, if it's thalassemia, then it's going to be thalassemia minor. The third differential diagnosis is sideroblastic anemia, and here there is a clue in the history that the lady is Cypriot, and this means that she is from the Mediterranean area. In this area, thalassemia is common. Thalassemia is extremely rare among Europeans. Next slide say that it's microcytic anemia, as we already said. Possible diagnosis: iron deficiency, thalassemia. Additional tests which should be done is the ferritin. The ferritin test the stored iron in the body, and it is the most important test in this respect. Okay, her ferritin was 50, which is with the normal, so iron deficiency is unlikely. The second test you should do is hemoglobin A2, and in her case the hemoglobin A2, as you can see from the slide, was 5% raised, and this confirms the diagnosis of beta thalassemia trait. Let's go to the second case. A 70-year-old Caucasian male complaining of recurrent mouth ulcers. His hemoglobin is 10, his MCV is 105, the white blood cells is 2.2, the neutrophils 0.5, and the platelet count 120. As you see that this patient has a mild anemia with a high MCV, indicates macrocytic anemia, but at the same time the white blood cells is low and the platelet is low as well. So this is a picture suggestive of pancytopenia. With recurrent ulcers, this should make you think that it could be a Crohn's disease. This could be a Crohn's disease, and as you know, Crohn's disease often affects the terminal ileum, and this is where vitamin B12 is absorbed. So vitamin B12 deficiency is possible. Okay, and in the discussion, as you see from the next slide, it's macrocytic anemia with pancytopenia, as we said early. Further investigation showed that the B12 is 180. Okay, this is low, of course. The serum folate is 5.5, which is normal. The liver function test was normal. Thyroid function test normal as well. And why did we do liver function test? Because often in liver disease the MCV may be high, and in hypothyroidism, again macrocytic anemia is possible. In this patient, the reticulocyte count is 25. The reticulocyte count should be normally about 1% or 0.8 to 1%. And why do we have a reticulocyte count of 1%? Because the survival of the RBC is around 100 days. And if we take the survival of the RBCs as 120 days, then the expected reticulocyte count will be 0.8. Okay, because the reticulocyte represent immature RBCs. Ultimately, they replenish the normal destruction of the RBCs. Let's go to the next slide. Okay. Okay. This patient was treated with a course of vitamin B12 injection. The classification of anemias is either microcytic, macrocytic, or normocytic, and this is quite useful. Let's go to the next slide. How do we start investigating any case of anemia? First of all, look to the hemoglobin. Usually the hemoglobin and the hematocrit is low in anemia. Okay, and of course if it's high, it indicates polycythemia. Okay. The MCV will tell you whether the anemia is microcytic, hypochromic, or normocytic. Let's go to the next slide. The red cell distribution width, RDW, this is a measurement of the size variability or variation in the size of the RBCs, and a common term which was very common actually, commonly used in the past, is anisocytosis. And N means none, iso means size, and cytosis means cells. So it indicates inequality in the sizes of the RBCs, and this is very much goes with the diagnosis of iron deficiency anemia. This doesn't usually occurs, the anisocytosis does not usually occurs with thalassemia, but its diagnostic value is not very high. Okay, so although it's a test which is commonly done whenever we find a microcytic hypochromic anemia, but usually we don't put too much weight on it. The diagnosis, as I said earlier, the diagnosis depend largely on the serum ferritin. And I'll say it again, if the serum ferritin is low, it indicates a normal iron status. If the serum ferritin is low, it indicates iron deficiency. And if the serum ferritin is high, it indicates iron overload. True, the ferritin is an acute phase reaction, and it may go up with inflammatory conditions, but this shouldn't make a diagnostic challenge, because if the patient has active rheumatoid arthritis or active ulcerative colitis or Crohn's disease, then this is usually clear. Okay, so if the patient hasn't got any of these conditions, and the serum ferritin in this case will be very informative. The next slide. Look into the differential diagnosis of microcytic anemia. As we said earlier, probably the commonest is iron deficiency, and in this case, the serum ferritin is low, the serum iron is low, and the TIBC, which is total iron binding capacity, is high. I wish to say something about the relation between the serum iron and the total iron binding capacity. These tests should be looked at together, not separately. Normally, the TIBC is 1/3 saturated by the serum iron. So in states of iron deficiency, the relation will be less than 1 to 3. It may be 1 to 5 or 1 to 6, because in this case the serum iron is low and the TIBC is high. In states of iron overload, the opposite will occur. The serum iron is high and the TIBC is low. So the relation will not be 1 to 3, it may be 1 to 2. Yes. The second is thalassemia. In thalassemia, the serum ferritin is usually normal, while the hemoglobin A2 is usually high, as you have seen in the previous case. Anemia of chronic disease sometimes can present as in this picture, although this is not very usual. In these cases, the serum ferritin is normal or raised. The serum iron is decreased and the TIBC as well. But in these cases, the ESR and the C-reactive protein are usually high. And as I said earlier, from the clinical picture, there is an active disease. Let's go to the next slide. How do we differentiate between iron deficiency and thalassemia? And by the way, is it important to differentiate between them? Yes, because in iron deficiency, the treatment is supplementary iron, while this shouldn't be given in thalassemia, because thalassemia is a chronic hemolytic anemia, and in chronic hemolytic anemias, usually iron absorption increases, and iron is a heavy metal, and if you give too much iron to a patient, it will get precipitated in different organs of the body. In the liver, can cause cirrhosis. In the pancreas, can cause diabetes. In the myocardium, causes cardiomyopathy. In the skin, causes pigmentation and irritation. And itching is a common complaint in patients with high iron. Okay. So in states of iron deficiency, the hemoglobin and the RBCs are usually low. The MCV is low. The MCHC is low as well. And the RDW is high. Thrombocytosis is a common feature of iron deficiency. Okay, and if you do a blood film, then pencil cells often seen in the peripheral blood film. In thalassemia, the hemoglobin is usually in beta thalassemia minor, the hemoglobin a little bit on the low side, decreased. It could be normal as well. And the MCV is low. The MCHC is usually normal. This is the main corpuscular hemoglobin concentration. The RDW is usually normal, contrary to iron deficiency, but as I said earlier, the diagnostic value for this is not very high. The platelet count in thalassemia minor is usually normal, and the film shows target cells. Let's go to the next slide. The slide on the right shows a blood film of a patient with thalassemia, and the slide of the left shows a patient with iron deficiency. In this slide of iron deficiency, you can see the pencil cells. You can see that the red blood corpuscles are of different sizes. Okay, and this is the cause of what we earlier called anisocytosis. Okay. and the cells generally are hypochromic. In thalassemia trait, the cells are of equal size, but they are hypochromic, and there are target cells, as you see. Um, um, how do we assess a case of suspected iron deficiency? As I said earlier, always confirm with serum ferritin. And it may be falsely normal with an active inflammatory condition, but usually this is obvious. And as we said earlier, the ESR and C-reactive protein under this condition is usually very high. If the serum ferritin is more than 50, then our iron deficiency is unlikely. An early deficiency or with mixed deficiencies, the MCV may be normal. And this mixed deficiencies, actually, I want to say something about the MCV here. Remember that in iron deficiency, although we call it microcytic hypochromic, but the first thing to occur is that the RBCs will go smaller in size. So microcytosis usually present earlier than hypochromia. And if the body cannot compensate by microcytosis, then hypochromia will occur. The mixed deficiencies may present some difficulty in diagnosis, and the typical example of this is in some patients with celiac disease. As you know, celiac disease is not rare, and usually it affects the duodenum and jejunum, causes villus atrophy, subtotal villus atrophy in this area. And this area, the duodenum and the jejunum, is where iron and folic acid are absorbed. Okay, so a patient can present with iron deficiency, which causes microcytosis, and folic acid deficiency, which causes macrocytosis. And here you may see two generations of RBCs. This is often called a dimorphic blood picture. But the aromatic analyzer may give you a normal MCV because he will take the resultant of the sizes of the microcytes and the macrocytes. But a blood film will show clearly under the microscope that there are two generations of RBCs, micro and macro. What are the causes of iron deficiency? Diet is probably one of the commonest causes in many countries. And here you have to know something about iron metabolism. Iron is taken usually, as you know, from diet, and a well-balanced diet contains about 10 milligram of iron, and iron metabolism maintained mainly by absorption. A male usually absorbs about 10% of this iron, i.e. 1 milligram, and a female in the reproductive period of life absorbs about 15%, which is 1.5. A male loses about 1 milligram of iron daily, and this is mainly by the shedding of gastrointestinal mucosa. In a female, the same shedding of gastrointestinal mucosa plus pregnancy, lactation, and labor. So a female needs iron, which is a little bit more than a male. Iron metabolism is maintained mainly by absorption, and as I said earlier, the absorption is in the duodenum and the jejunum. In states of iron deficiency, iron absorption will increase, but just a little bit. And in states of iron overload, iron absorption will be decreased, but again, just a little bit. So if you give too much iron to a patient, you can cause iron overload. and iron overload is quite harmful because iron is a heavy metal which can be precipitated in different organs of the body. Um, the second cause of iron deficiency, we said the first cause is dietary, and by the way, the main diet which contain iron are meat and dark green vegetables, mainly Spanish. Okay, and um, the second cause is malabsorption, and celiac disease is on the top. Chronic blood loss is the other common cause, and obviously one might think that a human being can lose blood from any organ. He can lose blood, for example, hemoptysis means loss of blood from the respiratory system, hematuria, loss of blood from the urinary system, but practically, the loss of blood which causes iron deficiency in males is mainly from the gastrointestinal tract, because a patient can lose a liter or two of blood in the gastrointestinal tract without seeing anything. Okay, of course, melena is the usual thing to be seen, but this is not always noticed by the patient. Plus, the fact that if the patient is oozing a small amount of blood, then he will not see it. While if a patient develop hematuria, then it it will be very obvious, very frightening to the patient, and very painful. The patient will present just like uh, a patient with renal colic because blood is irritant. Okay, in a female, second, the first is the uterus. They usually lose blood, so um, a patient in the a lady in the reproductive period of life can lose a big amount of blood by abortions, normal labor, etc. Okay, or even after menopause, abnormal uterine bleeding is a cause which need always to be investigated. Uh, let's go to the other slide. Um, what are the causes of failure to respond to iron? And by the way, um, uh, the treatment of iron deficiency should be supplementary oral iron. Okay, it should always be oral iron unless contraindicated. Okay, um, and for how long should we give iron? We should give iron until the anemia is corrected, and usually this takes a few weeks, probably 3 to 4 weeks in moderate anemia. And then you have to give iron for another 3 months to replenish the iron stores, because most of the iron in the body is not circulating in the blood. Most of the iron in the body is stored in the reticuloendothelial system and bone marrow. The causes of failure may be inadequate treatment, mainly not the duration was not long enough, or if the patient has continuous bleeding. Okay, a patient on aspirin, or a patient who has a tumor, whether benign or malignant, in the gastrointestinal tract, and you are supplementing the iron, but the patient continuously oozing blood, then again the anemia will not be corrected. A patient with malabsorption obviously will not absorb. Okay, and as I said earlier, the commonest example of this is celiac disease. Uh, uh, Poor compliance from the patient with the oral iron again is a cause, because oral iron often causes some side effects. It can cause some abdominal pain, abdominal colic, constipation. Okay, so the patient might not use them for long enough. So a detailed history will clarify the picture. Or the diagnosis was wrong from the beginning, and the commonest condition to be mistaken with iron deficiency is probably thalassemia minor. Parenteral iron is indicated. Please look carefully into this slide. And parenteral iron is indicated only if, for one reason or the other, you can't give oral iron. Okay, and these are the indications: genuine intolerance, malabsorption. Although if the malabsorption is due to celiac disease and you put your patient on a gluten-free diet, then if the patient sticks to his gluten-free diet, then within 3 to 4 weeks, the villi should go back to normal, and then iron absorption will be normal. Okay, but if you want to treat from the beginning with injectable iron, then this is possible. If a patient had gastric surgery, or again, or upper GI surgery, mainly, as I said earlier, the duodenum and jejunum, and inflammatory bowel disease sometimes, yeah. And these are the preparation you see on the right side of the slide, which are available for intramuscular and intravenous injections. The main problems with injectable iron is allergy and sometimes anaphylaxis. That's why I said the standard treatment is usually oral iron, unless you have a very good reason. Okay, let's go to the next slide. What are the causes of a high serum ferritin? Infection or inflammation, because as I said earlier, ferritin is an acute phase reactor, so it can go high in conditions like ulcerative colitis, Crohn's disease, active rheumatoid arthritis, etc. Chronic liver diseases, especially if it is alcohol related. Alcohol is a drug which enhances iron absorption. Plus the fact that some alcohol drinks, because they are stored in iron barrels, have a high concentration of iron. So iron overload very often occurs with heavy drinking of alcohol. Malignancy is another cause. Repeated transfusions. Okay, and when do we need repeated transfusions? Mainly in patients with inherited hemolytic anemias, like sickle cell anemia, thalassemia. That's why a transfusion should be restricted to necessity. The other cause of high serum ferritin is hereditary hemochromatosis. And in this case, the serum ferritin is very high, and this condition very often associated with organ damage, like the liver causes cirrhosis, the pancreas causes diabetes, in the skin it causes irritation and pruritus, and very often a dermatologist is the first one to diagnose hemochromatosis because the patient presents with itching. Porphyria cutanea tarda, another cause of high serum ferritin, and obviously the other cause is a prolonged iron therapy without the patient being iron deficient. Let's go to the next slide. This is case 3, a 65-year-old male, non-stable, mild chronic lymphocytic leukemia, CLL, and he is on no treatment. And here is the question: are we allowed not to treat chronic lymphocytic leukemia? The answer is yes. If the patient is stable, if the white cell is not very high, below 50,000, these patients usually do very well. And as you probably know, these patients usually are old in age, and very often they don't die from the CLL itself, they die from another cause. So there is no need to be very aggressive in treatment, but of course there are indications for treatment. In this 65-year-old male, it seems that his CLL was stable, but then he came to his doctor complaining of increasing fatigue and breathlessness. And on examination, he was found to be jaundiced. Okay, here jaundice may indicate hemolysis. And the second note on physical examination is that there is no enlarged lymph nodes or spleen. If you find a patient with a stable CLL, this sort of a presentation, increasing fatigue and shortness of breath, and you find that the lymph nodes are increasing in size, or the spleen, which was not palpable, is in large size, this indicates that the CLL is activated, or it may have turned to an acute blastic phase. Okay, but in this patient there are no lymph nodes, no spleen, and the patient is jaundiced. So what is the possibility? Let's see the investigations. The investigation here showed a hemoglobin of 8 and an MCV of 102. So this is macrocytosis. The white cell is 30, and this is high but not very high for a patient with CLL. The platelet count is a 300, and the bilirubin is 60, very high. This indicates hemolysis. Okay. Other liver function tests were normal, like the ALT, AST, and probably the alkaline phosphatase. So the presence of a high bilirubin, a low hemoglobin, and a normal liver enzymes indicate the presence of the possibility of hemolysis. In addition to that, you find that the reticulocyte count is 300, and this is of course very high, and this indicates that the bone marrow is responsive. The bone marrow is responsive, and it indicates that there is hemolysis. The LDH is an important investigation whenever there is hemolysis, and yes, it is high. It is 900. The conjugate bilirubin is 10, again high. Direct Coombs test was positive, and this means the diagnosis is autoimmune hemolytic anemia. And is autoimmune hemolytic anemia occurs commonly with CLL? The answer is yes, and usually it responds pretty well to corticosteroid. Okay. This is the discussion of the case, which we probably already covered most of these patients. Macrocytic anemia, macrocytosis due to increased reticulocytes due to secondary hemolysis. Hemolysis caused the jaundice. Hemolysis autoimmune, positive Coombs test diagnosis autoimmune hemolytic anemia. Complicating CLL, the treatment is corticosteroid, and as I said, the response to corticosteroid is usually very good. What are the tests for hemolysis? The initial evaluation should include liver function tests, okay, which obviously will show a high bilirubin, as it was in this case, but the liver enzymes are normal. The reticulocyte count is usually increased. The LDH is increased. The haptoglobin is usually low. Additional test, you could do a blood film which shows polychromasia, spherocyte, sickle cell. This is, if it's spherocyte, this may be congenital spherocytosis. If you see sickle cells, this is again maybe congenital sickle cell anemia. hemoglobin electrophoresis may be needed in the diagnosis, and the direct antiglobulin Coombs test, usually if positive, indicates autoimmune hemolytic anemia. Okay. Um, these slides shows examples of spherocytosis, congenital spherocytosis. This is a spherocyte, this is another spherocyte, this is a third one, and on the left hand side of this slide you see sickle cells. Okay. These diseases are common in Africa, extremely rare among Europeans, and they are not rare in the Middle East, particularly in the south of Iraq. Macrocytosis. What are the causes of macrocytosis? B12 and folate deficiency, chronic liver diseases, excessive alcohol intake, and myelodysplasia. These are the commonest causes of macrocytosis. Less common causes include hemolysis, as you have seen in the previous case, multiple myeloma, other bone marrow disorders, and hypothyroidism, thyroxine deficiency. A blood film in macrocytosis shows target cells in liver disease. These are target cells. Okay. And polychromasia is the other finding. Polychromasia, you can see it clearly in this slide. Okay. Here we have a slide of B12 and folate deficiency, megaloblastic anemia, hypersegmented polymorphs. This is a hypersegmented. You see how many segments are there, and okay. And in here you see oval macrocytes and poikilocytes. Okay. Sometimes in investigating macrocytic anemia, we may need to do a bone marrow, and the term in the peripheral blood is macrocytosis. The bone marrow term is megaloblastic, and this is a megaloblastic bone marrow. Megaloblastic bone marrow. What are the causes of megaloblastic anemia? First of all, megaloblastic anemia occurs when the hemoglobin is low and the MCV, main corpuscular volume, is high. The RDW can precede a rise in the MCV. With severe anemia, it can cause poikilocytosis, and the MCV, as we said earlier, is usually high, and the RDW is high as well. The film usually shows hypersegmented polymorphs, which we have seen already, and a blood test of LDH is usually very high. The increase in bilirubin is usually slight. Okay, usually there is a slight increase in bilirubin, and this is due to the fact that some of the RBCs formed in the bone marrow, if they are deficient on, say, B12, they might not survive for a long time in the peripheral blood, and this is called ineffective erythropoiesis. So they break down early, and this is the cause of high bilirubin. Vitamin B12 deficiency. Vitamin B12 deficiency is not rare, and if you miss this diagnosis, then it could the patient can can have damage to his nervous system, central and peripheral nervous system, plus the anemia. Okay, so it's a condition to be kept in mind. I'm sure you all know the metabolism of B12. B12 is usually taken from diet, and the main source of it is animal meat and the liver. Mind you, animals and plants cannot form B12. B12 is synthesized only by bacteria. Okay, but usually it's taken by animals and stored in muscles and in liver. And even the bacteria which is present in the large bowel of human beings usually synthesize B12, but B12 is absorbed in the terminal ileum, and the bacteria are present in the large bowel. That's why a human being does not use the B12 which is synthesized in his own large bowel. Okay, these bacteria will go out with the feces. It will be eaten by insects, and probably they will circulate in nature by this way. If you suspect B12 deficiency, then check the diet. Vegetarians are particularly prone for B12 deficiency, and they must have B12 supplements because vegetables have no B12 in them. The MCV, as I said earlier, is usually high, and the patient may be anemic. And neurological symptoms can occur. They mainly B12 deficiency can cause dementia, and it can affect the posterior column. So the patient present with ataxia as well, and peripheral neuropathy. Levels of B12 may be low during pregnancy. Okay, you can test for autoantibodies, and you can do the Schilling test, but if the B12 in the serum is low, then this is an absolute indication that there is B12 deficiency, and irrespective of the cause, the treatment is usually supplementing B12. Yeah, these are the figures of a normal B12. I want to say something here. You see the borderline of B12 is 200 to 250. I advise you not to accept the lower levels of normality in B12. If the B12 is normal but the level is on the low side, you better treat with B12. Yes. Folate deficiency, investigating for folate deficiency. This is the other slide. Again, you can check the serum folic acid, the serum folate, and usually the patient can, a patient who is anorectic or a patient who is fasting for a long time can develop folic acid deficiency, because contrary to B12, folate is not stored in the body in big amount. A patient can go folic acid deficient if he is not taking folic acid for a few weeks. Okay, while B12, usually the liver contains about 3 milligrams of B12, and the daily requirement is quite low, probably from 2 to 5 micrograms. So a patient can go for years, for probably 2 or 3 years without B12 before developing B12 deficiency. But as I said earlier, this is not the case with folate. Again, the MCV is usually high, and again, think of malabsorption, and the commonest malabsorption which causes folic acid deficiency is celiac disease. Okay. Isolated macrocytosis. Alcohol excess is probably one of the commonest causes of high MCV. That's why it's very common in the West, and that's why you see that the MCV is considered to be normal when it is above 100. But here we have seen B12 deficiency mainly with MCV in the 90s, and I believe the reason for this is that most of these figures are taken from the West, and the majority of people there drink alcohol. That's why what is considered to be normal in Europe is probably not normal. Probably this is due to the effect of the high alcohol intake among the population. So remember this, please. Excess alcohol is a common cause of high MCV. In this case, the gamma GT is a very important enzyme. The gamma GT is high usually among alcoholics. Chronic liver disease is another cause of high MCV, and if you find that the serum albumin is low, then it indicates chronicity, because as you all know, the albumin has a half-life of 3 to 4 weeks. So if the albumin is low, it indicates chronic liver disease. Pregnancy is another cause of high MCV. Myelodysplasia, another cause. Drugs, and particularly these drugs, because they are in recent years, not only in recent years, but these three drugs, hydroxyurea, methotrexate, and azathioprine, are very often used in conditions like rheumatoid arthritis, immune hepatitis, etc., and they all can cause a high MCV. Let's go to the fourth case. A 60-year-old male complaining of breathlessness. His hemoglobin is 9 and the MCV is 88. White blood corpuscles and the platelets are normal. Okay, this indicates that there is a moderate anemia, but the other indices, the white blood corpuscles and the platelets, are normal. Plus the fact that the MCV is within normal, so this is normocytic, normochromic anemia. Okay. How do we investigate this anemia? Of course, we have to request a complete blood count or a complete blood picture, CBC. Okay. And thyroid function test we often do as well, because thyroxine deficiency can cause anemia, either macrocytic or normocytic. Liver function test, the ESR in this patient was 30 and the creatinine was 250. So the creatinine is high. This indicates probably this anemia is due to a chronic renal failure, secondary to chronic renal failure. Okay. Additional test can be done here is the serum erythropoietin level, and this is often low in a chronic renal failure. You may check the ferritin, because in patients with chronic renal failure, although ferritin deficiency is common, but iron deficiency is more common. So many types of anemia can occur in association with chronic renal failure. The commonest is iron deficiency. So please, before labeling this patient's anemia, as due to erythropoietin deficiency, make sure that the patient is not iron deficient. Okay. The diagnosis is anemia secondary to chronic renal failure. Treatment in this patient is erythropoietin. Normocytic anemia. This is non-specific, and most hematinic deficiencies cause can be seen with iron deficiency, combined deficiencies, recent bleeding, anemia of chronic disease, can be microcytic as well. How do we evaluate a case of anemia? First of all, do a full blood count. I myself usually look into the hemoglobin. If the hemoglobin is low, I look to the white blood cells and to the platelets. If the white blood cells and the platelets are normal, then this anemia is due to something wrong with the RBCs only. But if you find that the patient is anemic while the white blood cells is sky high, then this may indicate leukemia. If the white blood cells is low, the platelet is low, the hemoglobin is low, then this is a picture of pancytopenia. Okay. Bone marrow may be indicated, and a blood film examination is quite useful. Reticulocyte count is again useful, and as I said early, the reticulocyte count, if it is low in anemia, it indicates that the bone marrow is not responding in the appropriate way. Okay. And you can do the renal function test, the liver function test, C-reactive protein, and sometimes protein electrophoresis if you suspect one of the chronic hemolytic anemias, thyroid function test if you suspect thyroxine deficiency. Functional anemia classification. Okay, it could be increased loss. This could be acute or chronic. Okay, and blood loss usually leads to iron deficiency anemia. Increased destruction, again, all hemolytic anemia, all processes of hemolysis will lead to anemia. Decreased production, this usually indicates a diseased bone marrow or some deficiencies like erythropoietin deficiency. Okay, metastasis to the bone marrow, multiple myeloma, leukemias, all these can cause anemia due to affection of the bone marrow, because as you all know, the bone marrow is the organ where the RBCs are formed. Failure of the bone marrow could be secondary to erythropoietin deficiency, or as we said earlier, due to metastasis or invasion with myeloma and leukemia. Thank you very much. This is the end of part 1, and hopefully, inshallah, we will have part 2 data interpretation on hematology. Thanks for your attention.